Okay, everyone, welcome back. We are going to be covering the appendicular skeleton today. But before we do so, I want to give you a little bit of an overview of what to expect on exam 2, which will be osteology. Now, it'll be a similar setup to exam 1. It'll be 50 questions. It will be, you will have to type in the answer, again, like you did for the first exam. It is all identification. And I'm going to give you a little bit of a breakdown as to about how many questions you will expect to see on different parts so that it will help you focus some of your studying. All right. So you will see the skull, you will see the vertebrae, you will see the spine, you will see the sternum, you will see the ribs, you will see the scapula, the humerus, the radius, the ulna, the hand, the pelvis, which we'll cover today, the femur, which we'll cover today, the tibia, that we'll cover today, the foot, and we'll have the osteon again. Now, we did the osteon, you saw on exam 1, but we're also going to see that on exam 2, so that should be a little bit of a refresher and some give me points that come from that. In terms of the skull, you can expect about 17 to 18 questions just on the skull. So there's a lot on there. There's a lot of landmarks. So that's historically, whether it's online or on campus, the skull is the biggie. And that's where a lot of students go, hopefully you won't ask that much on there. Let's do the other. But the skull is super, super important. You have to know the main bones, right? You're going to have to know, is it a frontal bone or a temporal bone or parietal bone? Is it a sphenoid bone? If it's a sphenoid bone, is it the lesser wing of the sphenoid? Is it the greater wing of the sphenoid? You'll have to know the mandible and the different parts of the mandible. Is it the mental foramen? Is it the mandibular process or mandibular protuberance? Is it the angle of the mandible? Is it the ramus of the mandible? Is it the coronoid process of the mandible? Is it the zygomatic arch? Is it the maxilla? Is it the mastoid process, styloid process? So some of the questions are purely identification, and some of them you'll have to know the part and the bone. For example, if it is the, let's say, mandibular process or mandibular protuberance, the word there, mandibular, tells you the bone. But if it's the mastoid process and it's only asking for name this part, then it's mastoid process. If it's named the part and the bone, then it's the mastoid process, and then you put the bone that it stems from. If it is asking, let's say the, let me think of another one. Let's just for simplicity, if it's asking for the supraorbital ridge or the supraorbital foramen, and it asks what bone, frontal bone, right? So there are some of them that are clearly off of certain bone. Let's say it's pointing to the greater tubercle. Well, greater tubercle, humerus. If it's pointing to the, let's say it's pointing to the capitulum, capitulum humerus. Trochlear, humerus. Sometimes it's asking for the part, and then sometimes it says name the part and what bone. Okay, so you don't have to put a comma, and do not put a comma on the exam, meaning the answer key won't recognize them, and it'll create much more work and chaos for everyone if you put greater tubercle, comma, of the humerus. No, just put greater tubercle humerus, lesser tubercle humerus, radial fossa humerus, olecranon fossa humerus. Okay, radial styloid. It would be redundant if you put radial styloid radius, right? Just the word radial tells us it's on the radius. If it's ulnar notch, that's radius. Radial notch, ulna. Okay, so just read the question carefully. Sometimes it's only asking for the part. Sometimes it's asking for the part and the bone that it comes from. Okay, so make sure you study that skull. Make sure you know all the foramen, what the foramen look like. If you're looking inside the skull, and if you turn the skull upside down, you can also see them. Okay. Make sure you know the foramen rotundum, foramen ovale, foramen spinosum. Make sure you know the carotid canal, the jugular foramen, the hypoglossal canal, the external auditory meatus, the internal auditory meatus, the supraorbital foramen, infraorbital foramen, mental foramen. There's just lots of holes. Magnum foramen, right? Make sure you study them in clusters or groups. So if you want to take a sheet of paper, you may put bones, you may put foramen, then you have another one, processes. Just study them in a variety of ways, all right? So about 17 or 18 just on the skull. On the vertebrae, there'll be about 9 questions on the vertebrae. And that's a combination of things like simply just name the part of the vertebra, whether you are asked spinous process or transverse process or vertebral body, pedicles, lamina, superior articulating facet, inferior articulating facet, superior articulating process, inferior articulating process, right? Some of those basic parts. You'll also have to identify and know the difference between a cervical vertebrae compared to a thoracic vertebrae compared to a lumbar vertebra. There are some key differentiating characteristics to each. You have to be sure that you know the difference between what C1 looks like and C2 vertebrae, or atlas compared to axis. You have to know that atlas has an anterior arch, it has a posterior arch, it has a posterior tubercle compared to a spinous process, where once you go down a level and you're looking at C2 or the axis, now you'll see a spinous process that forms, and it's bifid. C2, C3, C4, C5, they all have spinous processes, but not the atlas. It just has an anterior and a posterior arch with a posterior tubercle, little bump to it. Remember that the cervical vertebrae, all of their transverse processes, have foramen through them. It's called the transverse foramen. And that transverse foramen is for the vertebral artery to travel through, to make it up into the brain. It comes off the heart. This vertebral artery comes off the heart, goes upward or superiorly, and goes through the transverse foramen of all the cervical vertebrae to get into the brain to feed the brain oxygen and bring glucose in there. So know the key landmarks that differentiate the atlas from the axis. Remember the dens or the odontoid process. You'll see that on C2, but you will not see that on C1. If I give you the spine and a picture, an illustration of the spine, you can identify which vertebrae it is. Is it C6? Is it T4? Is it L3? You have to know C is for cervical, T is for thoracic, L is for lumbar. So you have to know there's 7 cervical, 12 thoracic, 5 lumbar. So you don't want to miss a simple question like that. You have to know the sacrum, the different parts of the sacrum, and the coccyx. So there'll be about 1 or 2 on the sacrum or 1 or 2 on the coccyx, nothing too crazy. But those 9 questions include vertebra all the way down to the sacrum and coccyx. There'll be about 1 or 2 on the sternum, 1 or 2 just on the main parts of the rib. There'll be at least 2 to 3 on the scapula, 2 to 3 on the humerus, 2 to 3 on the radius, 2 to 3 on the ulnar, and about 2 to 3 on the hand. Now today, we're going to be doing the lower extremity. So I'm going to bring around 2 to 3 from the pelvis, about 2 to 3 on the femur, 2 to 3 on the tibia, 1 to 2 on the foot, and about 3 to 4 from the osteon. Okay, so that will give you a little bit of a breakdown as to what to expect on the exam, which will be next Tuesday. The exam time starts again when your class starts. It will open up at the beginning of the class time, and you'll have to do it in sequential order, just like last time. If you know the answer, you write it down. Once you advance to the next, you have all the time you need, within reason, because I think if there's 50 questions, I think it's 50 or to 60 minutes. It'll tell you when the exam opens. I have to look at the past history to look at class averages in terms of average times that it takes from the least to the most, and then what the average is. And that's how I come up with the estimated times. When you know the answer, you write it, submit it, and then you go to the next question. It'll only show 1 question at a time, like the last one. When you advance, you can't go back. If you don't know it and you skip it, it will automatically mark it wrong. So put something down to try and get some points, if you could. Okay, let me share my screen so we can get into the PowerPoint of the pelvis today. Let me bring up. Okay, that looks about right. Okay, let's share the screen here. Okay, can you see my screen? Just give me a thumbs up if you can see it. Perfect. Okay, so this is a PowerPoint that I added a few days ago. It kind of goes along with the similar one that we covered last week when we did the axial skeleton, which is everything here that we see highlighted in the center. Today last week we also did the upper extremity. Today we're going to be looking at the hip bones. Most people refer to it as the pelvis, and we're going to work our way down to the foot. So sometimes the hip bone is referred to as coxa, and the hip bone itself, or the pelvic bone, is made up of these three primary bones. It's made up of the ilium, which is the largest. Then we have the ischium, and then we have the pubic bone, or pubis. When the ilium, the ischium, and the pubis ankylose or fuse, it creates this socket that's referred to as the acetabulum, or it's also referred to as the acetabular fossa. They're both acceptable terms, acetabulum or acetabular fossa. The very, very top of the pelvis up here is referred to as the iliac crest. That's the top part. Now, when you follow the iliac crest, you can either move anteriorly to it, moving this way, or we can go posteriorly and we move down and backwards this way. When we move anteriorly, you'll find anteriorly, if we move downward, the pubic tubercle, which is pretty sharp. It's a pointy part. So when you find that pubic tubercle, that's anterior, okay? Once you find anterior, it helps us with these two landmarks called the anterior superior iliac spine and the anterior inferior iliac spine. When you put your hands on your waist and you slide your hands forward around belt line, where the belt is in the front, there's this little ticklish spot on most people, and that's this bump right here, the ASIS, or the anterior superior iliac spine. When you go inferior to it, it's the anterior inferior iliac spine. And these are important landmarks because when we do muscles, for exam 3, the ASIS is a landmark for the longest muscle in the body is going to attach here, called the sartorius. And then in second place, there's a muscle that originates on the AIIS called the rectus femoris. It's one of your quadricep muscles. Now, when we follow it, the iliac crest to the posterior side, we're going to find a posterior superior iliac spine and then a posterior inferior iliac spine. So in the front, there's an ASIS, an anterior superior iliac spine, and on the back, a posterior superior iliac spine. On the front, an anterior inferior iliac spine, and on the back, an posterior inferior iliac spine. That large cavity again is the acetabulum or acetabular fossa. On the posterior side, there is a large notch, which is right here. And this large notch or depression that we see here, this cavity, this space, is referred to as the greater sciatic notch. So what do you think is going to travel through a greater sciatic notch? Sciatic nerve. The sciatic nerve is going to come down, all the way down, and it's going to go through another notch called the lesser sciatic notch. And there's a structure that separates the greater sciatic notch from the lesser sciatic notch, and that landmark is called the ischial spine. Not to be confused with the ischial tuberosity, which is, if you're sitting down, the bone that all of us are sitting on, it's called the sit bone. It makes contact with the chair or the couch, whatever it is you're sitting on. It's called the ischial tuberosity. Ischial spine is much smaller. Ischial tuberosity is a broader contact right here, and it's also an important landmark. It's an important landmark in which the hamstring muscles will originate. So for exam 3, when we get into muscles and I point to a muscle that's one of the hamstrings, I may ask you in the future, where does this muscle originate? And you have to retain and hold on to this information that we're doing now on osteology. So all of these bony landmarks have significance. They are important because they're muscles or ligaments or tendons that attach to many, many bony landmarks. Okay, so let's review what we've done so far. We have the iliac crest on top. When you follow it forward, ASIS, AIIS. You follow the iliac crest back, PSIS, PIIS. Now on the exam, you can't abbreviate, you have to write them out. Okay, don't put ASIS, I'm just abbreviating for us. Know the two notches, the greater sciatic notch and the lesser sciatic notch with the ischial spine that separates the two. Ischial tuberosity, which is where the hamstrings originate, is posterior and inferior. In the front, pubic tubercle. This large hole in the center is called the obturator foramen. It's the largest foramen in the body. The obturator foramen is the largest. Now, this is what one of the innominate bones or one of the pelvic bones look like from the outside. Remember, the acetabulum is lateral. So if we wanted to look at what this bone looked like from the other side, from the inside, now we have to look at the illustration on the right. And there is this smooth depression in the front called the iliac fossa, right? This is the ilium. This is still the ilium, but from the front, this inner depression is called the iliac fossa. And there is a muscle that originates here called the iliacus, which is a primary hip flexor. From this view, you could still see the greater sciatic notch and the lesser sciatic notch and the ischial spine that separates it. Here we get a better view of the pubic tubercle, and this surface here is where the pubic symphysis, which is cartilage, which runs vertical up and down, separates the right innominate bone from the left innominate bone. We'll show you that cartilage in a second. Again, you can see the three major parts: ilium, ischium, and the pubis. This is what it looks like all together, right? So when we're looking at it from the front, here's the L5 vertebrae, here is the sacrum, here is the iliac crest. On the inside is the iliac fossa. When you follow this to the front right here, this little bump would be the anterior superior iliac spine, but down here would be the anterior inferior iliac spine. When we look at it from the posterior, we follow the iliac crest to the back. That first big bump is the PSIS, posterior superior iliac spine, and then below that, posterior inferior iliac spine. On many people, if here's the belt line, you can often see this in the summertime if people are wearing bathing suits and it tends to drop a little bit and you see this upper part of the lower back. Many people have these two dimples, one here and one here, and sometimes a little bit deeper in certain individuals. Those dimples is this gap or space between the PSIS, or the iliac crest, and the sacrum. It's typically right here. It represents what we call the sacroiliac joint, the space between the sacrum and the ilium. Those are one dimple would be here and the other dimple would be here. Okay. And you can see the sacroiliac joint from the front. That's this joint here. All right, what else can we see? We can see the sacral foramina, which are these holes. We could see the median sacral crest, which would kind of be equivalent or an extension of the spinous processes, but they're not called spinous processes in the sacrum. Here's the pubic symphysis. That's that cartilage that we saw. It's fibrocartilage. It's very strong. It's very similar to the cartilage that we have here going horizontally, called the intervertebral discs. Here is the pubic tubercle. You have another pubic tubercle in the front here. 2 pubic tubercles. Here's the ischium. Ischial tuberosity would be here. It's the roughened part, more towards the bottom that you'd be sitting on. There's the obturator foramen, the largest foramen in the body, acetabulum or acetabular fossa. Here's the coccyx. Sometimes it's 3 segments, sometimes it's 5 segments, depending on the individual, but it's 3 to 5 fused segments. This can fracture when people fall and they land on it. It's often painful when it dislocates or fractures. There is neurological tissue that attaches here to the coccyx. When we do neurology, we will learn about the 3 meninges, and we'll see that one of the meninges can actually anchor itself to the very, very tip of the coccyx, which is why when people slip and fall and they land on their butt, they get this pounding headache either the same day or later the next day. You can also understand why when the pelvis itself tilts, whether it tilts laterally where one innominate bone is higher than the other, if you get a tilt, or you get an anterior or a posterior pelvic tilt, it changes the orientation of the greater and the lesser sciatic notch. And the sciatic nerve can actually pinch or hit any of these parts of this bone, causing what we call sciatica. Okay, here's a nice colored picture of the sacrum, ilium, pubic bone is everything here in pink, and then the yellow would be the ischium. Here's the coccyx and the pubic symphysis. Anterior superior iliac spine, anterior inferior iliac spine. Iliac crest on top. Iliac fossa. Up here, this is the pubis. Down here, this is the ischium. This is the ilium. Pubic tubercle here, pubic tubercle here. There's a ligament that goes from the pubic tubercle upward to the ASIS. Goes this way, and another one goes this way. If you ever look at those old Calvin Klein ads for men's boxers, right? Sometimes you can see in certain men, you could see this ligament here stick out, and then this ligament here stick out. It kind of adds to the appeal of a lot of those advertisements. Okay, let's see if there's anything new here in this picture to show you. Nope, nothing new here. What I wanted to show you here is how do we determine whether if we find bones or there's a dig somewhere this happens a lot in Greece, just about anywhere they dig, they find artifacts and they find skeletons. It's pretty amazing to go to the trains or to the subways in Greece because the subway stations look like a museum because when they dug them, everything's preserved behind glass. You can actually see skeletons and fossils. It's wild. But to determine and differentiate between a male pelvis and a female pelvis, the male bone is obviously larger, it's thicker, it's wider, and this a lot has to do with hormones like testosterone, making the density of the bones thicker and heavier. But if we look at the angle here at the pubic symphysis, the male angle here is 90 degrees or less, and the female pelvis, if we draw a line along the inner brim of this, it's 100 degrees or greater. And if you were to add a line through the pubic symphysis and a line here, some may say it looks like the difference between a wine glass versus a champagne glass, right? Upside down. But the female pelvis is wider because reproductively, there's a baby that's going to be housed in here, right? So this potential of this pelvic inlet and this brim to be wider so that a baby can grow and a baby can rotate and turn is critical. Structure determines function. Okay, let's look at the femur, which is the longest bone in the body. Remember that the head of the femur, much like the head of the humerus, has to project itself medially. And it has to articulate with the acetabulum or the acetabular fossa. At the very, very inward tip of the head, there's a slight depression called the fovea capitis. It's this little depression here. There's a little ligament that will attach to the fovea capitis, and it goes to the most inner part of the dish or the acetabulum that it articulates with. As we move distally, this is the head of the femur. Now we move down into the neck of the femur. And as we move distally again, now we have these two large processes or protuberances that come off of it. The larger one is the greater trochanter, which is lateral, and the one that's more medial is the lesser trochanter. Now, do not confuse this with the greater tubercle and lesser tubercle, right? I mean, both the humerus and the femur both have a head, they both have a neck, and they both have a greater and lesser something, right? The humerus has the greater and lesser tubercle, whereas the femur has the greater and lesser trochanter. In the front, there's the intertrochanteric line that kind of runs on this oblique angle from greater to lesser. And on the posterior side, there's the intertrochanteric crest going from greater to lesser. On the posterior side, there is a sharp line on the posterior side that we do not have on the anterior side. The line on the back is called the Linea Aspera. The Linea Aspera is posterior. If you look at the direction of the shaft, you'll see from lateral to medial, it runs on this oblique diagonal medially. See how that angle? It's not straight up and down, it goes on an angle. On the inside or medial side, there's a medial epicondyle, and then lower a medial condyle. Remember, epi means above. So there's a medial condyle, flat, right? It's at the most inferior surface, which will articulate with the bone inferior to it, called the tibia. And so will the lateral condyle. So the lateral condyle and medial condyle of the femur will articulate with the tibia below it. Above the lateral epicondyle is the lateral epicondyle. So there's a medial epicondyle, a lateral epicondyle. Medial condyle, lateral condyle. It's the medial lateral condyles that will articulate with the bone inferior to it, which is called the tibia. Above the medial epicondyle, there's a little bump, a little tubercle called the adductor tubercle. When we do muscles, for exam 3, we will learn 3 adductor muscles: adductor longus, adductor magnus, and adductor brevis. So just keep that adductor tubercle in mind. In the front of the distal end of the femur is a smooth little surface where the kneecap will articulate with. The kneecap is called a patella. So this is just the patellar surface. Again, femoral head, femoral neck, greater trochanter, lesser trochanter, intertrochanteric line, shaft of the femur, patellar surface, lateral epicondyle, lateral condyle, medial epicondyle, medial condyle. On the posterior side is the Linea Aspera. In terms of the kneecap, the top of the patella is called the base of the patella, and the inferior part is called the apex of the patella. On the underneath surface lies the facets, either a medial facet or a lateral facet. Remember, the facets are just smooth surfaces that are designed for two bones to actually make contact or articulate with one another. This is anterior, this is posterior. When the underneath surface starts to break down or degenerate, there's a lot of clicking that goes on when people bend their knees. And there's improper tracking mechanism of the patella here on that patella surface. So every time your quadriceps contract, the patella glides up and down in this surface. And when the surface starts to degenerate or break down, that's called degenerative joint disease or osteoarthritis. It's very, very uncomfortable for people. There's a specific name for knee degeneration, especially when it's under the patella, and it's called Chondromalacia Patella. Chondromalacia Patella. All right, let's look at the leg bone, right? The femur is considered to be the thigh or the hip, right? When people use terms like hip flexion or thigh flexion, it means, okay, what is the femur doing? When we talk about the tibia and the fibula, that's the leg or the knee. So they'll say knee flexion or leg flexion or knee extension or leg extension. So if you were to kick a ball, that would be knee extension or leg extension. If you step on something hot and your leg flexes, that would be knee flexion or leg flexion. The leg, which is tibia and fibula, would be analogous to the forearm, which is radius and ulna. The arm, the humerus, would be analogous to the hip or femur or thigh. So sometimes we'll say arm flexion, which is humerus flexion. They'll say shoulder flexion, again, humerus or arm flexion. They're synonymous. All right, let's look at the lower leg. This larger bone is the tibia. It is the more medial bone, whereas the lateral bone, the outside bone, is the fibula. Notice the fibula doesn't originate at the same level as the tibia. So when we look at the knee joint, the fibula really doesn't make or play a role in the knee joint. If we look here at the purple, right, you see you have the femur, you have the patella, and you have the tibia. The fibula does not really play a major role in making up the knee joint. The fibula and the tibia play a major role in making up the ankle joint, which is more distally. But knee, primarily femur, patella, and tibia, structurally speaking. When we look at the proximal part, there is a lateral tibial condyle, and then there's a medial tibial condyle. And between the two is a bump. That bump is called the tibial tubercle or tibial tuberosity. This bump, which we all have, and we can all palpate it and feel it on ourselves. If you're sitting and you go inferior to your kneecap, we're all going to have this little bump. This tibial tubercle is a very, very important landmark. It's where your quadricep muscles insert. And at the same horizontal plane, right, if we go from here and we go horizontal in that same direction, it takes us to the head of the fibula. If we were to draw a line in this direction, they make the same horizontal line, tibial tubercle or tibial tuberosity and the head of the fibula. If we look at it from the posterior, you can still see the head of the fibula here, and there is an intercondylar eminence. Intercondylar eminence are these two bumps. You can't really see it from the anterior view, but if you look at it from the posterior, you can see it here. It's like the top of the mountain right there. Intercondylar eminence. Okay, remember the larger, thicker bone is the tibia, and the smaller one is a fibula. Just remember, it's okay to tell a small fib, right? A small fib. So the smaller bone is the fibula. Now, as we move distally, you will see that the tibia becomes a prominent structure and the fibula becomes a prominent structure. It's the malleolus. The one on the medial side is the medial malleolus. The one on the lateral side, lateral malleolus. The lateral malleolus and medial malleolus play a very important part of the ankle joint. It reminds me of a monkey wrench. If you've never seen a monkey wrench, just Google it. You'll see that these two parts and the way this joint comes together is very much similar to the mechanism of how a monkey wrench works. I also want you to notice that the lateral malleolus, which is an extension of the fibula distally, extends further distally than does the tibia and the medial malleolus. And why is this an important feature? It's an important feature because it helps to explain why most ankle injuries happen with the foot rolling inward. If you think about someone slipping down the stairs or slipping off a curb, the foot would plantar flex, which is like stepping on your tippy toes. That's plantar flexion. And the foot would invert, which is bringing the sole of your foot inward or medially. So that type of injury, a plantar flexion, inversion injury, or the ankle rolling inward, is super common. And it creates a lot of black and blue, a lot of bruising, a lot of swelling around the front and lateral side of the ankle because a lot of those ligaments are being overstretched and possibly torn. It is very, very rare that the ankle rolls laterally because the lateral malleolus blocks the mechanism of the ankle rotating that way. But because there's nothing blocking it on the inside, the ankle rolls inward. Okay, now looking at the foot from a bird's eye view, right? We're looking downward onto the foot. This is the superior view. The bone that articulates here with the lateral and medial malleolus is this bone right here, called the talus. This is the most superior bone. So this will act like a monkey wrench and clasp both sides of the talus. Now we're doing the tarsal bones. Remember, in the hand, we had 8 carpal bones. In the foot, we have 7 tarsal bones. The most superior is the talus. The most inferior one that makes the heel is the calcaneus. As we move anteriorly, anterior to the talus is the navicular. Anterior to the navicular are 3 cuneiform bones. Cuneiform bones, there's 3. You can either refer to them as the first cuneiform, second cuneiform, third cuneiform, or cuneiform 1, cuneiform 2, cuneiform 3, or the way it's written out here, which is medial cuneiform, intermediate cuneiform, and lateral cuneiform. They're all synonymous. Lateral to the lateral cuneiform is a bone called a cuboid. Okay, so those are the 7 tarsal bones. 1 is talus, 2 is calcaneus, 3 is navicular, 4 is the cuboid, and then 5, 6, 7 is medial, intermediate, and lateral cuneiform. Those are the 7 tarsal bones. In the hand, you had 8 carpal bones. Everything else is kind of the same as the hand. Remember, in the hand, we have 5 metacarpals. In the foot, we have 5 metatarsals. Metatarsal 1, metatarsal 2, metatarsal 3, metatarsal 4, and metatarsal 5. Distal to the metatarsals are the phalanges, or the phalanx. Remember, just like the hand, digits 2, 3, 4, and 5 have a proximal, a middle, and a distal phalange, or a proximal, middle, and distal phalanx. The unique one is the great toe, known as the hallux. There's only a proximal. This is a little typo here. It should say, there should be an L at the end. It should say proximal. So there's a proximal phalange or phalanx and a distal phalanx. Same as the pollicis of the hand or the thumb. Okay, so 7 tarsals, 5 metacarpals, and then 14 phalanges. Proximal, middle, and distal, proximal, middle, distal, proximal, middle, distal, proximal, middle, distal, but the great toe only has a proximal and a distal. Okay, if you're ever asked on an exam, what is this? This is the first metatarsal, or metatarsal 1. If it points to here, this is the second proximal phalange, or second proximal phalanx, either way. From the side view, we show this. This is from the medial side, just showing the arc or the arch of the foot. There's always arcs in the body. It's really important to have this longitudinal arc and to have a transverse arc. When these arcs fall, it's called pes planus, which is flat feet. And I would say 7 to 8 out of 10 people have a degree of pronation of the foot or flattening of the foot called pes planus. In my office, I happen to do a 3D thermographic scan on all of my patients, evaluating their foot structure, because it's so important. It's really important because if you think about standing, depending on what the foot does, if the arc falls and you have flat feet, it works its way up the tibia, works its way up to the kneecap, works its way up to the femur, and everything of the lower extremity rotates internally or medially. And it puts a lot of strain on a lot of the hip muscles when the lower extremity rotates. It can cause sciatica. And then the technology is able to evaluate the right foot compared to the left foot to see which is flatter. And then the hip or the pelvic bone will drop. Obviously, it will become unlevel or tilted on the flatter side. And remember, when the pelvis tilts or drops, then what happens to the greater and lesser sciatic notches of the pelvis? That entire orientation changes. It can cause sciatica. So that's where we make flexible, customized orthotics to slip into the shoes to help increase and bring back the normal architecture of the foot. Okay, here's just a close-up view showing the talus, calcaneus, cuneiform 1, 2, and 3, or medial, lateral, and intermediate cuneiform along with the cuboid. Then metatarsal 1, 2, 3, 4, 5. Then you have the proximal, middle, and distal phalanx of toes 2 through 5. And the first one only has a proximal and a distal phalanx. Okay, the great toe is called hallux, and the thumb is called a pollex or pollicis. From the side view, you can see the talus, you can see the calcaneus. Many people who have high arches, many people who are runners, have high arches. The fascia underneath the foot is very, very tight, and it pulls from the calcaneus to the toes. Think of it as a bow and arrow, right? When you pull on the strings or the muscles, the bow increases, and that's called pes cavus. That's a high arc. When you decrease the tension on the muscles this way, it flattens out, becomes more straight, called pes planus. When you have muscles pulling on the heel, pulling, 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 because they're super tight, the calcaneus starts to develop a little bone spur right here called a calcaneal bone spur, and becomes very, very painful. The clinical history to this is when patients will say they get up in the morning, they're barefoot, and as soon as their foot hits hardwood floor or hits the tiles, it's super painful when the heel contacts the ground. This is the perfect candidate for foot orthotics, where they put in a special cushion to make sure that the orthotic itself acts as a shock absorber for the calcaneus, so that that sharp bone doesn't crush nerves or muscles underneath the foot. Okay. Okay, great. Let me stop the screen share there, and let me stop the recording.